Hello, everybody. This is Sharon Hicks from Open Minds, and I wanted to welcome you to our webinar, A Robust Practice Management System, Your Key to Success. We'd like to also thank NextGen Healthcare for sponsoring this webinar about this very important topic. A few housekeeping issues before we get started. All attendees are on mute, but please feel free to type any question that you have into the chat or question box. We'll be monitoring these and we'll make sure that we have adequate time for questions at the end of our presentation. And then finally, to demonstrate their commitment to the financial health of our human services and behavioral health marketplace, we want to thank NextGen for underwriting the cost of a number of financial assessments that were previously only available to elite members of Open Minds. Anybody on this webinar is going to be able to access those assessments and join our community discussion at our Whole Person Care headquarters, which you can find on the web at wholepersoncarehq.com. Whole Person Care HQ is one word. Again, thank you so much to NextGen for making this possible and for sponsoring this very important webinar. With that, let me turn it over to our first speaker, Javier Favela.
Hi, everybody, and welcome. Very excited to this webinar topic is extremely important, really building systems to build a better, robust practice management system, which is really ultimately the key to success. Just to put a finer point on what Sharon had mentioned earlier, if you could go to the next slide, please. So we have launched the Whole Person Care headquarters, which Sharon had mentioned. And this site really provides access to best practices. You get access to all of the webinars that we've put on, topics, articles, financial tools, white papers, as well as information centered around integrated whole person care, community behavioral health, and tools to serve human service organizations. As Sharon mentioned, we have actually launched and made available free of charge to members who join Whole Person Care headquarters a financial assessment tool suite. Available today, we have a financial strength calculator, a financial sustainability assessment. We will be adding to the set of tools a competitor financial analysis tool, as well as a financial strength expansion compatibility calculator. As Sharon had mentioned, you can visit the site at chq.com. Today's objectives, and it is really focused, centered around technology. How do you use technology to build a better and more robust practice management, really leveraging technology to optimize workflows and optimize revenue cycle management, ultimately impacting your days in accounts receivable and your key financial performance indicators, navigating audits efficiently and effectively, and using automation and technology to do that, and best practices that leads to closing faster and accurately. Today's presenter, so my name is Javier Favela. I'm the Vice President of Solutions at NextGen Healthcare. We also have our key presenter today, Jerold Greer. He's the Chief Information Officer at Daymark Recovery Services. Just a little bit of background about myself. Before I came over to technology, I was the Chief Financial and Operating Officer for a large community mental health and integrated care organization out of Arizona. I ran the accounting department, the business intelligence division, as well as the claims department. So this is a key topic for us, where it's near and dear to my heart, really bringing some of those best practices and bringing it to technology to help organizations be successful in financial performance. It's no doubt that the healthcare and human service delivery system is constantly changing, continues to change on a regular basis. And really, you know, what we want to focus on today, and really what most organizations are concentrating on, is really aligning incentives to help energize clinicians. We're seeing a lot of providers and clinicians and rendering providers. There's a burnout with technology, helping streamline some of those workflows so that they can actually truly do their job and serve the people that they're taking care of on a daily basis, and automate using technology to, at the front end, all the way through to billing and revenue cycle management. There's also a key focus on better managing the people that we take care of by improving experience and engagement, assuming risk and drive commercial advantage, and optimizing using interoperability and technology to optimize workflows using data exchanges and technology to really improve the experience of a clinician. But most importantly, those last two and first two that you see right in the middle, you see maximize and shape financial outcomes. Ultimately, we do great work, but at the end of the day, we have to get paid. And this is challenging. And really, all of these changes that are happening is the changes. It's challenging, but it does matter. And so what we're going to be talking about today is really using technology to automate workflows and streamline your business to really, at the end of the day, get paid and see better financial performance. So many organizations, right, as they're evaluating with the changes in the future of healthcare, really thinking about what's important. We're seeing lots of changes in the space, whether it's M&A activity, there's consolidation, or you're still an independent organization. At the end of the day, we're working with organizations to stay financially healthy and really chart their own destiny. As I mentioned earlier, the patient and provider connection is absolutely important. So really making sure that you're creating a connection between the provider and patient, whether that's a virtual front door, meeting the patient where they are, or services, your traditional services in the office, but better connectivity between the patient and the provider. And again, to the point of meeting the patient where they are, we're seeing in the behavioral health and human services space more access to virtual care or telehealth technology, and even remote patient monitoring in the homes. Complex reimbursement models. It's like the wild, wild west in behavioral health and human services. We're seeing a shift from your traditional fee-for-service to value-based care reimbursement or alternative payment models, making it more difficult for organizations to actually manage and manage their financial performance. We're constantly dealing with regulations and reporting changes, still very heavy in behavioral health. Better coordination with staffing and patients, and then using outside data, interoperability to make better informed decisions, ultimately with the task of reducing costs, improving care, and reducing health disparities in the communities that we work in. At the pillars of everything that we do with organizations, it's really centered first and foremost of making sure systems are integrated. And Jerold, in a little bit, is going to be talking about that. Right? You need an integrated set of solutions, ultimately improving the end user experience, both provider and patient, bringing outside data, connecting to other systems to make better informed decisions, and bringing that, that data into meaningful information to provide better insights at the point of care to make those better informed decisions. And then ultimately, what we do every day is to have an impact on the people that we take care of. And so outcomes that make a difference in the patients and the communities in which you serve. So today's key focus is really making sure that organizations are successful with their revenue cycle management. And what Jerold's going to talk about and spend most of today is front end, using technology, automation to really improve in the back end, right, improve the collections and revenue cycle management process. And things that we work with organizations and think about, right? So eligibility, pre-service financial clearance, better systems automation to reduce the workload. In today's world, right, we have a labor shortage. The more that we automate, the less burden that we're putting on administrative tasks. And using technology for rules-based charge engine to get clean claim submissions first right out the door, better claims and AR management, and then how to manage contract audit and recovery. And so with that being said, I'm going to turn it over to Jerold, who is going to give you the perspective from Daymark Recovery Services.
Thank you, Javi. I'm Jerold Greer, Chief Information Officer at Daymark Recovery Services, and it's possible that some of you know me because I've been doing presentations in a national environment for over 30 years now. But most of those have been vendor-centric presentations, and it's only been recently that I've gotten into the arena of doing more vendor-agnostic presentations. And my specialty over the last several years has been really developing technology and implementing technology around whole person care. And with this coming out of the whole person care headquarters, then you'll see an inclination for me to build anything into any presentation that touches on whole person care and interoperability and how ultimately that will drive workflows and even revenue optimization. So for today's presentations, while topics that I have embedded in here will include the complexities of North Carolina, parallels exist in every state's behavioral healthcare system. We'll cover clinical and administrative efficiencies, and sometimes I'll get into the weeds, but not too techy. The system in use at Daymark is NextGen Enterprise. However, some of the concepts have evolved over nearly 20 years without integrating the best of our innovations into our NextGen implementation. We did implement NextGen just over 4 years ago in our agency, which meant we had a system selection to go through. And one of the things that we said on the very front end is that we can't select a system that cannot adopt the innovations that we had historically implemented, as we saw that as a weakness. And so a system that could not, they simply were not eligible as a replacement system when we went through that process. And we did not want to look for a system where we had to ask for source code changes from a vendor. We needed one that was flexible enough that allowed our team to implement what we needed. So we were looking for design flexibility. And for those of you that might be a NextGen user out there, then I wanted to make sure to say that anything that I touch on that shows a visualization of NextGen, our implementation of NextGen is highly customized. And that's by choice because we had developed a number of things over the years that were well suited to our environment in North Carolina. NextGen offers solutions out of the box that work very well for many environments. But we see that as very much a strength that NextGen allowed us, its architecture allowed us to build to our needs. And just kind of give to help create a theme for the presentation, I threw in this one slide, the power of reimagining workflows, to help illustrate an example of a situation where in one of our growth phases of Daymark, we won an award to operate 9 outpatient walk-in clinics in 8 counties. And those clinics were transitioning from a state-operated model to the private sector. And in that transition, there was a significant cut in the funding. The management of that prior operation, from their perspective, optimized workflows prior to the handoff. They wanted to try to make it easy for the provider that would win the RFP. But they still had too many FTEs, admin and clinical, for budget allocation. By leveraging the power of software customizations, we reduced the overhead of a single function from what was 9 FTEs from the optimized model of the prior management to what we saw as 1.5 FTEs. And 1.5 FTEs turned out to be on the high side under that new model of workflow management that we created. We're continuously revisiting all operations just about every single day. With the pros of that means that we're living within our means, because it seems that as we have inflation around us, rates for services do not keep up with the costs, and often we have to deal with that by reducing our admin overhead. So we can adapt our systems, become more efficient, live within our means. The cons being, how many of you remember being able to go down the hallway and say, is there anybody that can take on this task for me? Those days seem to be over. The more effective I am and my team is in making operations more efficient by leveraging the power of a platform like NextGen, the fewer people I have to go down the hall or virtually across our organization at our 40 sites to say, can somebody help out with this? Just a quick visualization of who we are as Daymark. This map, actually, I left a couple of things out of this, the yellow representing our points of physical presence. But Chatham County, we're opening a facility in Charlotte in January. Buncombe County are just a couple of the instances of places not represented in this map. Next slide. Our service array, we were founded in 2003 as part of North Carolina mental health reform, where there was an elimination of the traditional catchment area in favor of competition. We've grown to approximately $70 million in annual revenue, serving about 50,000 patients annually, which is growth from our year one of existence when we were serving about 12,000 patients in only 5 counties. And we've grown to having 28 outpatient walk-in clinics, 7 inpatient, what we call North Carolina facility-based crisis units, 3, soon to be 4 BHUGs, or behavioral health urgent care units. And we have multiple intensive in-home teams, assertive community treatment teams, mobile crisis programs. On August 31st, we became certified as a care management agency, and in short, that's a whole person care management program, and I'll touch on that in just a moment. We're also CARF accredited. We are a CCBHC, and we've been a meaningful use or promoting operability agency, having implemented the workflows to support funding for that for the past 10 years, having pulled down about $3.5 million through that program. And just a quick snapshot from our website of showing the locations from that perspective. And then a quick look at our payer landscape, because we can't really go into the presentation about efficiencies and practice management without understanding who we are and what we're evolving through. And for the first several years of our existence, really up until about 3 years ago, well, through 6/30/2021, it started to change a little bit before then, we were operating under these 7 geographic regions represented in this map, and almost all of our funding came through the correlation between where a patient lived and who was managing the county where that patient lived. But now we move just a next day on the calendar, and we have a much different representation. On 7/1, we went through something called Medicaid transformation. And when I speak of Medicaid, in North Carolina, we do not have expansion in North Carolina. And because of that, we are very reliant on state funding for those that are at or below 300% of poverty level, with about 60% of our revenue coming through that state funding. For the state funding, we have 6 regional payers, which pretty much align with the 7 payers I demonstrated on the prior map. However, one of those payers dissolved, and the counties were assimilated into the remaining 6 payers. And then on the Medicaid side, we have 11 primary Medicaid payers. 4 of those are statewide standard plan PHPs, and these are new Medicaid payers that came in as part of Medicaid transformation on July 1st, and 1 regional PHP. And patient choice defines the payer in that case. But we also have 6 regional tailored plan payers, and these are custom payers that primarily serve patients that we would expect to see in the SPMI SED population. A lot of when the standard plan model was implemented on 7/1, a lot of the SPMI SED population defaulted to this tailored plan model. But despite that, members could still choose a statewide standard plan. So I may have defaulted to, say, Healthy Blue. I'm sorry, may have defaulted to Via Health, which is a tailored plan. And I want to be under the Blue Cross plan Healthy Blue. I could still select that and bounce out of that one model to the other model. However, in doing so, that could exempt me from certain services, because some services such as assertive community treatment team, intensive in-home, are only available in the tailored plan model. Under the tailored plan model, the county of residence defines who the payer is. rather than, you don't have that state wideness. If I live in Cabarrus County, North Carolina, where I'm sitting right now, then my payer, if I'm under a tailored plan, is going to be Partners Behavioral Health Care, and I don't really have a choice in that case. Bottom line, with all of this complexity between state funding, 11 Medicaid payers, which I won't say it's unprecedented, but in the world of Medicaid payment models for behavioral health care, I think it's pretty on the high end of complexity. If NextGen can handle this environment, then I think it can handle pretty much in any behavioral health care environment that is out there. So as I noted, I tend to tilt toward clinical or whole person care, and I also tend to tilt toward clinical workflows. And we're looking at practice management. I've had a shift in my mentality where practice management really starts in the clinical workflow, because if you can focus on getting it right the first time on the clinical side, then you have so few downstream problems. How many of you have dealt with issues where you had to request authorization for services but found out the clinician didn't fill out this form, and you had to go back and ask them to complete this under this circumstance? So what I've done here is I've drawn a picture just to lead into the discussion of what our clinical assessment looks like inside of NextGen, with each of these tabs across the screen opening up panels and subpanels. So don't let the single screenshot misguide you. There's a great deal of complexity under each of those mouse clicks. I shouldn't say complexity. There's a great deal of breadth to the assessment options available through those workflows. But what I'm highlighting here on what I call the conclusions tab is a button in the center called finalize, because that is the very end of the workflow. That's the point where I'm going to take all of my work and I'm going to create the document out of that process, and I'm going to create the charge for that. I'm going to create the, in this particular workflow, what is typically the 90791 assessment charge. So this gets into the guts of what we're doing with the clinical workflow. And we have embedded within every form, within every workflow, something that I like to refer to as hack points. And even when we were selecting our next system, one of our score measures was the hackability of the platform. We actually created that metric, hackability. So we created 3 hack points within every workflow within the system in order to say, I want to stop and do something. I want to assess something, and I want to check out the circumstances. And based on the circumstances, I want to do something, alter the workflow. So those 3 defined hack points we call before script, which means I want to do this before you start the workflow or before you open a form. For example, you need to do something else before you continue with this workflow. An example in that case is that when our clinicians got to the point of doing an authorization request, then there were certain data points that our payers did not allow to be more than 14 days old. So it would do the analysis at that point and say that, oh, this particular form, like the last ASAM that was done, is 15 days old. That will not be allowed to be submitted. So before you continue here, you need to go back to the ASAM and refresh it, and then you can come back and complete this process. Then we implemented the end script, where you want to do this as you try to finish the workflow or a form. For example, validations. If you get to a step in the process and you put this value into a field, and based on something that you did earlier in the workflow, it doesn't make sense, it would stop you at that point and say, well, it doesn't make sense. We need to go back and you need to do what makes sense in order for this value to tie back to this value. For example, the diagnosis that you selected for the service may not fit within, in North Carolina, what we use is the language target population or benefit plan. So you need to either alter your benefit plan or you need to alter the diagnosis so that those match and ultimately can be paid for the service. And then we have the after script hack point, which means that I want to do this after you've finished the workflow. For example, I want to send data somewhere. As soon as I finish this workflow, I want to bundle up the data. And for example, I can go as far as saying I want to send a claim. As soon as I submit the form, it's a billable service. I might go through all the way through the process of generating the claim, taking it through an FTP process, identifying the payer, dropping it on the payer's platform to really optimize the turnaround time on the claim. One of many, many reasons. I can also have an example in here where we can send value-based indicators to a value-based analysis platform. So in the example screenshot on the clinical assessment, although it could have also been a progress note, the finalize generates the billing and produces the clinical document. And the finalize triggers the end script that I indicated before to make sure that there's a valid service order. And if not, it launches a service order request. And that request will go to an MD or a nurse practitioner, which are the eligible staff that can sign off on that service order, who will review the chart and sign off by midnight. And I can confidently say that because within our organization, we have at least 60 MDs and nurse practitioners, a number of which are going to be up until midnight, just doing what they do as part of their job, covering duties, ensuring that certain tasks like that are covered. Something else that I might do is make sure that the specified duration is valid for the indicated service. Here's something that I know is a challenge for some agencies is if a controlled substance was prescribed, then did the prescriber check the state controlled substance registry? If not, force the workflow before finalizing. A lot of times these registries are designed as separate websites, but this is integrated into our workflows and logs when a person has checked the controlled substance registry, and will force the prescriber to check in the workflow if they did not do it beforehand. Another example is that they specify a substance use diagnosis, but they don't specify during the assessment workflow the substance use details, which is the typical state form of what's the primary drug of choice, what's the frequency of use, which is often a state funding requirement. In our case, in North Carolina, down to a service level. We're not going to get paid for a service if that information is not on file. So at that end script level, or to go back and say, you need to go back and finish that form before I can let you click finalize. Is the diagnosis valid for the benefit plan, the target population? And those being North Carolina terminologies. Telehealth, require the office location of the patient. When you're billing Q3014, we need to, at least in North Carolina, the patient has to be within one of our own facilities. We often see patients from one facility to another facility, and we need to ensure that we need to draw a distinction between the patient that is being seen in their home through their own device versus a patient that is being seen in one of the facilities that would then qualify them for the facility code billing for Q3014. And those are just several simple examples that a lot of you could relate to, but we have dozens of other validations that would fit within the scope of doing an end script just in that single workflow. Practice efficiency, case number 2, care management, and this is a big one, and I'm going to touch on a number of areas within this to include alternative payment models, because this is an example of a program where that applies. North Carolina is implementing a new program called Tailored Care Management. The program officially went live from a marketing and let's get our patients ready perspective on September 1st. And the reimbursement model that I'm describing here goes live on December 1st. And under this program, every patient is classified, every patient that qualifies for the program is classified into 3 tiers, low, moderate, and high. And each of those tiers require a number of different monthly contacts. And regardless of the number of contacts, we're going to be paid a flat rate. But we're still held accountable to the minimum number of contacts. So the high acuity level requires 4 monthly contacts, 1 that's in person, and we'll get a paid rate of $395.06. And a moderate tier, 3 monthly, 1 in-person quarterly, $269.66. And a low acuity tier, 2 monthly and 2 in-person annually, with a monthly rate of $162.08. Typical care managers will have a mixed acuity caseload of about 66. We can have 8 care management FTEs per team, which will give a team caseload of approximately 530 members. And this is a lot of complex tracking for care managers, individual care managers, and supervisors alike, and for billing case rates. So how do we keep up with all of that complexity? So herein, start to describe some of the flexibility that we have within NextGen. The screen that we have here is at the top level is pretty much NextGen centric, but below that you get into completely our custom design, and this is what we're calling our care management dashboard. And when I sign on to NextGen as a care manager, then I'm going to come right into our care management dashboard that is going to tell me exactly what we need to do, what I need to do as a care manager, and focus on, for that particular day, the appropriate patients that ultimately, how does this fit into practice management? It's going to maximize my potential revenue as a care manager and my potential revenue as a team leader for my entire program, and drive the success of the program and the success of the agency. So I have, in this particular screenshot, I indicated on the prior slide the complex contact requirements for each of the members within the program. So we said, how are we going to keep up with that? Because normally that would require a lot of spreadsheets, a lot of indicators. How and when am I going to sort through who needs to be seen and whether or not need to be seen in person or not? So we leveraged the adaptability of the NextGen platform to take that down to a mouse click. So all I have to do is go into our NextGen dashboard, and if you can see the screen well, I've got a checkbox that says needs additional contacts. When the care manager clicks on that checkbox and clicks on search, it's going to analyze their caseload in real time and instantaneously pull back the cases that are needed, that need contacts for that month, to ensure that we will get the case rate for the members in their caseload for that month. And this is hierarchical in its design. So while this is a view for a single care manager, if you see the provider filter in the upper left, if that provider is actually the supervisor of the team, I mentioned before that the supervisor may have 530 cases that fall under their domain. That analysis would occur for everyone within their domain. So it analyzed 530 cases. If you are the care management director for the agency and you have several thousand cases that need to be analyzed, that care manager director would see everyone across the agency. So everybody's going to do a lot of focus on this in the last few days of each month to make sure that everyone meets their contact requirements. So also within care management, keeping the focus here, the care manager is responsible for the quality measures of the whole person. They need to make sure that the patients have their well care visits, that they're controlling their high blood pressure, that they have their breast cancer screenings, that they're adhering to their medications, that they have the appropriate immunizations, avoidable utilization, their unmet resource needs met. And this can be summed up by the care managers being responsible for the total cost of the care, a metric of the program. And what's really extremely important about that from a practice management perspective is that a big part of the revenue for this program is not going to be those case rates. It's going to be incentives, which are not completely defined yet. They're most likely going to be driven by Medicaid savings. I know that Tennessee has implemented a similar model of this, and they're about 4 years ahead of us. And 25% of the Medicaid savings go back to the providers, and which can be summed in millions of dollars. And I anticipate that's pretty much going to be the model in North Carolina as well. And remember, I noted earlier that with the elimination of the catchment areas, that the environment is competitive, and not all providers qualify as care management agencies. Consequently, Daymark may be assigned to care manage a patient treated by a competitor across the street. And I literally have, where I'm sitting in our office now, a competitor that is a competitor that's across their parking lot that will in fact not be a care management agency. And we're going to see an influx of not patients. We have to update our terminology that we're using. It's going to be an influx of members that we are care managing that are their patients. But also in some cases, that provider across the street may be a certified care management agency. So they could in fact be seeing patients, members that are our patients. So it can go both ways. So the contacts with patients are not contacts where we're just calling up and saying, how are you doing? Because they're not check-in contacts. Contacts are largely driven by triggers as defined by the Tailored Care Management Program. And in most of the cases, the triggers will require a reassessment of the patient. And some examples of when we have to reassess the enrollee and do an updated care plan are when a member's circumstances, needs, or health status changes. That's very broad. Significant changes in scores to state-approved screening tools, such as a locus, CalLocus, ASAM level. An inpatient hospitalization for any reason. So that person you're treating for bipolar disorder, or the person across the street is treating for bipolar disorder, ends up breaking their arm and going to the hospital, then we're going to have to reassess that patient. 2 emergency department visits since the last assessment, or even an arrest, a loss of housing, pregnancy, and many, many more triggers. Too many triggers to be manageable for human tracking. So next slide, please. So to accommodate all of the triggers, Daymark's NextGen implementation receives real-time admission discharge information from hospitals statewide. The system queries the health information exchange at least daily for everyone in the program. It queries the national healthcare ecosystem at least daily through a network called Equality. It queries the county court records for arrests, and it consumes claims data from the state Medicaid system. And we at Daymark enhanced the NextGen implementation to continuously scrub incoming healthcare data. And this is what that means. We're continuously analyzing the data. So when we go out and we scrub care equality, where it's looking nationally across the healthcare ecosystem, and our analysis says, oh, I can see where one of our members that's under our management, their PCP just diagnosed a patient with hypertension. That's a new diagnosis. That enhancement, our enhancement of that data scrubbing will notify the care manager by tomorrow, and automatically the hypertension, add the hypertension to the care plan. And if a member is admitted to the ED at 1:30 p.m. today, the enhancement will notify the care manager by 3 p.m. today. That's the real timeness of our being in touch and connected. That's the interoperability that Javier was talking about earlier in his part of the presentation. So with all that going on, all that data scrubbing happening on a continual basis, how do we manage that? So then I come back to the dashboard and I turn that just into a simple checkbox. Notice I have on this slide, has a triggering event. So I simply check has a triggering event. I hit search, and it brings me back with all of my cases that have triggering events. And I've opened up one of the patients on this slide to show you what they see at the very beginning. We got simple demographics, but right in the middle, front and center are is the ADT fee, the admission discharge fee. So that's all of the real-time information coming into us from emergency departments, from hospitals. And if I got an ADT trigger, then I go over here and I'm going to see the specific detail of where that trigger came from, what hospital, what emergency department happened, and why did the person show up there. And one of the things we require is acknowledgement of those triggers along the way. So nothing can go by unacknowledged. Somebody will have to click on that and say that I recognize this, and because of this, I'm going to set a date for updating their care plan and updating the assessment. So finally, a part of this care management dashboard program is that we have to close gaps in care. So as I noted, we have to make sure that they have their well care visits. We have to make sure that they have their age and gender specific exams completed, that they're being adherent to their medications. And for this, we added the NextGen population health module that's constantly scrubbing not only our own clinical data, but also taking in the Medicaid claims and determining all of the instances that they've had, the screenings they've had, the well care visits they've had, the dental exams that they've had, all the preventive care visits that they've had, and coming back with a list of what's not been done across the population. So for each member, the Pop Health system determines the gaps in care. Daymark's NextGen dashboard enhancement is aware of the calculated gaps in care, and the care manager from the dashboard that we're looking at before can simply click on gaps in care. That will give them the list of patients that they can focus on and to help close those gaps in care, because they will be responsible for saying, I need to contact your PCP, or you need to, if you need help scheduling that appointment, if you need transportation to get to that appointment, then that's what we're going to work out during this session. So one of the things that we've seen during COVID, of course, is that we've had to kind of improve or optimize our models around seeing people on demand. So by contract, the way we are modeled in the state of North Carolina, our 28 outpatient clinics offer walk-in services that we call open access. We call them walk-in services. I know that some states and regions might call them open access. The model was originally constructed around the model of in-building resources, and the in-building resources would be modeled for the populations of the counties, and we serve counties that range from 11,000 to 400,000. Therefore, we have highly variable staffing patterns, and payers are reluctant to credential staff across county lines, and that's been something of a barrier that we need a solution for. Locations had inconsistent walk-in protocols that lowered throughput and reimbursement percent. And what was the pandemic impact? We had a loss in administrative staff and clinical staff. Losses became long-term as North Carolina telehealth policies became permanent. And the smaller the county, the greater the impact. So our solution for that was we transitioned walk-in access into universal access. So under this model, our regional managers, they were where they were reluctant to embrace change before, they were struggling so much that they were ready to embrace change with localized staffing issues. And payers were forced to break down access issues, eliminating their location-specific contracting issues. We embraced software development, enhancing NextGen to create a universal access queue where every walk-in across 28 locations must be registered, whether it's a physical walk-in or a telehealth visit. And the registration immediately queries statewide health information exchange and hospital systems directly through Care Equality. And all resources, once dedicated to in-building walk-ins, redirected to monitoring this new statewide universal access queue, which is visually drawn. And people go into this queue and self-assign themselves on a first in, first out basis, first patient in, first out, with some overrides to that methodology. For example, where we might need an LCSW match for a Medicare patient coming in. So we'll do a watch on the credentialing for that. With the Universal Access Queue, interacting with the NextGen practice management EHR the entire time. So it really is an extension of the platform, touching everything and staging workflows along the way. So case number 4, Medicaid eligibility. So with 11 Medicaid payers, and with members, even with the regional payers presenting at opposite ends of the state, we've seen cases of routine mass reassignments. We had 1.7 million reassignments, Medicaid reassignments in the state of North Carolina on July 1st, just as an example. We had hundreds of thousands of reassignments on September 1st through 12/31 to a dissolving payer that I referenced earlier. Over 200,000 being reassigned in the future in December of 2022. And this is not just a matter of who to bill. Financials are impacted. For example, a Medicaid payment for a 99213 can range in North Carolina from $55.42 to $232. So keeping up with those reassignments is extremely important for what revenue to expect. The units permitted before prior authorization can range from 8 to unlimited. And within that unmanaged, they're not provider specific. So if a patient walks in the door, we have to assume that they're out of unmanaged visits, that they have no freebies, so to speak, left because the provider across the street may have used them before they came into the door. It's been a matter of a requirement in North Carolina to do eligibility queries prior to every service, each with multi-page results that we had to scan and store into our system, which was countless hours of data entry managing all of these changes. So next slide for the solution. We implemented Medicaid 270, 271s, the electronic version of these queries, and decided that we're just going to routinely check everyone. So we implemented these electronic transactions and doing an average of over 5,000 queries a week. And we took the enhancements beyond just identifying changes in Medicaid. So with the Daymark enhancements, we do the following. We identify self-pay patients that ended up turning up Medicaid and automatically adds the payer information to the practice management platform. If the Medicaid payer is switched among the 11 payers, it lapses the old payer and adds in the new payer automatically. If the primary care provider has changed, which is noted in the 270 return, and important for care management, it records the change and sends an alert to the care manager who must formally update the care team and possibly other specialty care changes that may accompany that primary care change. If the care management agency changes, if it's not Daymark, then it records that change. And if Medicare was identified, but it wasn't on file for us, then it notifies the appropriate staff to do a full Medicare query to make sure that we have the appropriate Medicare information or the Medicare Advantage program. Value-based payments. We're turning into an environment where the amount of money that we get paid is not just tied to the fee-for-service environment that we have, but it's paid to seeing patients frequently and keeping it out of the emergency room. But one of the things that becomes problematic is a lot of times that value-based payment data is managed through a separate web portal. So you sign into a separate web portal and you go in and say that our clinical staff did this on this date, and we don't have the admin. It's expensive and sometimes more expensive to have the admin overhead than it would be to receive what you're getting out of the value-based payment. For example, we might say that we're going to get a value-based payment for the submission of X number of assessments over a duration of time, such as PHQ-9s, GAD-7s, CFARs, etc.
Jerold.
Uh-huh.
Hi, Sharon. We have about 10 minutes left. We do have a series of questions. And And I'm wondering if one of the questions is specifically related to value-based. I'm wondering if I could ask it now. One of our participants asked if you've seen any value-based care offerings that combine both the responsibilities to get paid and also for producing better financial performance. In other words, are any of them related to kind of metrics about the efficacy of your practice management system, the ability to report from your practice management system on services that have occurred? And I'll ask Javi about that question as well.
Yeah, and that is a pretty loaded question because there's a lot of answers to that question.
I think it's why it's the first question I'm asking.
And so for an example of an answer to that question, I think that ties back into that is the requirement to see patients within 7 days post discharge. So one of the facility-based crisis programs, for example, we have to see patients with an eligible service within 7 days. This very much gets into the logic of your practice management system and your clinical system, because not every payer recognizes the same type of service as an eligible service within the next 7 days. So what comes into play? Well, one thing that comes into play is making sure that you have dropped that person into a queue to make sure that they're tracked to be seen within 7 days, not just scheduled for 7 days, because it's likely they're going to fail showing up for a scheduled appointment. So how assertive do you get when they fail to show up for that appointment? And when they do fail to show up for that appointment, then what are your options for seeing that patient? Because this payer will accept this billing code, the other payer will accept this billing code. So yes, we've been able to take our system and put up guardrails around the program to say that this is what you can do with this specific patient. Otherwise, we won't get paid, and we will be penalized if we don't meet a certain measure. We might even be fired as a provider within a network if we're not adequately meeting those performance benchmarks.
One thing that I've seen that really, I think, speaks to the importance of practice management systems is value-based payments in which the insurance company is netting out monies already received based on kind of fee for service with the balance that might be due for the value-based. So in that case, the ability to not just bill for, but also receive and report in monies received is mission critical when you're trying to reconcile what you might be owed for the rest of the value-based.
I think there's 3 important questions that need to get answered when you're evaluating systems. I think obviously first and foremost, your practice management system being able to support complex reimbursement models. A lot of the organizations that we work with have a very diverse set of ways they get paid, right? They've got traditional fee for service, they've got value-based arrangements. In some cases, they're subcapitated. So a system that supports alternative payment models in addition to your traditional fee for service. A lot of what we see with value-based care, right, is based on being able to track the data and being able to report it out, right? So your reporting and business intelligence capabilities within the system is absolutely critical. And then a system from a clinical workflow perspective that puts a lot of the guardrails and automation that Jerold is talking about. So I think there's 3 important factors there when you're evaluating the system to be successful with what you're trying to do with alternative payment models.
And one thing, I'll wrap up this case here real quick, and then we can go into the broad Q&A. But my point here with the value-based efficiency is that we couldn't afford to add admin overhead to keep up with 11 different Medicaid programs and all the state payer programs to go in and do data entry to say we deserve this payment. So we leveraged NextGen's interoperability platform, specifically APIs, application programming interfaces. Basically, when something was met, when the value-based indicator was met, it automatically posts it to the platform that it needs to be posted to in order to get that payment. But it also creates the receivable. So it'll create the charge, and we're keeping track of that and what to expect based on that value piece.
Yeah, to Jerold's point, a lot of value-based care or alternative payment models are really, when you think about technology, interoperability is key, right? So being able to analyze your own data, bring in outside data, whether that's claims, clinical, financial, and being able to turn that data into meaningful insights at the point of care, right? A lot of value-based care arrangements or alternative payment models are taking action on these high risk, high cost, high needs members that you're serving. So population health and care management and interop is also key to evaluating the system.
And if I could add to that, like I said, our success is going to be based on if our patient or if our member had their well care visit within the last 12 months or not. So one of the things I didn't point out on one of the prior NextGen slides is that every time we open a chart within NextGen, it's going to tell us where they're missing out on those quality indicators. That is going to be a lost opportunity for incentive, value-based. So it will tell us we're missing a well care visit, we're missing a mammogram, we're missing, and every person in our agency, from the front desk to the physician to a care manager, can be a part of closing that gap in care that ultimately will result in a value-based payment.
That's really important. I think that the whole agency is aware. I think we only have time for one more question. So the next question that I received was, what KPIs other than things like days in AR are you are in your standard kind of reporting, metrics? Like, what are the things that leadership expects to see out of practice management? Besides things like days in AR?
Yeah, there are a series of KPIs that I think are really important to a claims and a business intelligence team that's evaluating their, how they're getting paid, when they get paid. I think really important to add to that KPI list outside of the days in AR is a claim first time claim submission rates, and then subsequent after that. How quickly are you getting paid? What's the gap between the data service and when charges go out the door to payers? Looking at denials, so percent of claims denied due to either front-end edits or coding errors. It could be, typically what we see, and I love Jerold's use case 4, what are your top denials? A lot of times it's eligibility, right? Usually member not enrolled is usually the top denial code. So really having a good understanding for what those what services are getting denied, the top service codes, the top payers that are getting denied, and why, right? And how do you work to remediate those challenges? What we've done is, while we didn't cover it today, is there's an appendix that will be provided in the deck that actually has a set of KPIs. I think there's 10 of them in there that I think will be helpful to many of the organizations on the call.
That's great. And unfortunately, we're out of time. I want to thank you both again for this really informative web briefing. Obviously, practice management is something that needs a significant amount of attention and probably doesn't get spoken about as much as it should. So thank you all very much. Thank you to our attendees.
So if you do want to learn more about NextGen Healthcare and even more about what some of the content that Jerold covered today, you can visit us at www.nextgen.com, and we'll be happy to engage and help you learn more about the solutions that we bring to the table.
Thank you all very much.
Thank you, everyone.